Hello and welcome to the Consultation Skills Part 7. I'm Dr. Alex and I work at the Christian Medical College in Vellore in South India. In Part 1 we saw the benefits of good consultation skills and how it is about providing better care for your patients, not just being a nicer doctor or other health professional. In Part 2 we looked at the Calgary-Cambridge Guide to the Medical Interview, looking at the 5 phases and 2 running themes in each consultation. And in Part 3 we looked at power and control in the consultation and how that can help or hinder good communication. We saw that as health professionals we need to give some of our power to the patient so that their agenda can be fully expressed. This is the big idea, and it is otherwise known as patient-centeredness. Instead of the health professional being at the centre of the consultation, they help the patient to take the centre spot. So how do we do this? We are aiming to make the consultation a meeting of experts of disease and illness. We learned about 3 essential skills, the first of which was the golden minute, allowing the patient to tell their story in their own words for up to 1 minute without interrupting. In the last presentation we looked at our second essential skill, DICE, difference or disability, ideas, concerns and expectations, areas we need to ask the patient about in order to reach our expert conclusion. Our final essential skill is shared decision making. After the physical examination, we enter the phase 4, explanation and planning. At this stage it's a good idea to summarise again everything you have found out about the patient's illness, including what you have or have not discovered in the examination. You need to explain your understanding of the problem in words the patient can easily understand. This explanation should be in terms of both disease and illness. Incorporating the patient's perspective is important in giving the explanation meaning in the patient's understanding. You may have decided about what is going on and reached a diagnosis, or you may have a short list of possible differential diagnoses, or you may have no idea about what is going on. But whichever it is, you will probably have some idea about what to do next. In shared decision making, you should offer the patient some options about what to do. This may be treatment or investigation, or doing nothing, which is always an option. Doing nothing is an option that many patients choose anyway, despite what we suggest or prescribe for them. Up to 50% of prescriptions written by doctors are not taken properly, and many are not taken at all. In some circumstances, doing nothing may be a very, very bad option. Someone with symptoms and signs of meningitis needs antibiotics quickly. However, for the vast majority of patients, there will be more than one possible way to manage the situation they are in. And doing nothing rarely means doing absolutely nothing. Watchful waiting is a phrase we use to describe a period in which no active treatment is given, but a patient monitors their symptoms for any changes. Watchful waiting can be very effective, as many situations resolve spontaneously without treatment. It can also be effective if you are not sure of the diagnosis. A period of watchful waiting can be helpful to see how things change, which may confirm or rule out a possible diagnosis. It can be helpful to get the patient to keep a diary of their symptoms day by day. What people recall when they look back over a period of time when you ask them in the consultation room can be quite different from what they write down as a daily record of symptoms. You need to outline the benefits of different options and also the possible risks. Here's an example. A child of 18 months has pain in their ear. They have a mild fever and the eardrum looks inflamed and dull and may be bulging slightly. It's difficult to see because their child keeps moving. The options are immediate antibiotics. Secondly, delayed antibiotics. Take the prescription and get the medicine from the pharmacy in 3 days if the child is no better. Or thirdly, wait and see with a review in 3 days. You can say to the mother, it is not possible to tell if this is caused by an infection by a bacterium, which will respond to antibiotics, or by a virus. Most infections like this clear up on their own within a few days. We have 3 options. I can give you antibiotics straight away. They may or may not help, and may give the child diarrhea. I could give you the prescription, and if in 3 days he is not getting better, then take the antibiotics, or take them sooner if he's getting worse. Or, thirdly, we could wait and see, take medicine for the pain and fever, and I will see you again in 3 days. Which of these would you like to do? Or, for an older woman with knee pain caused by osteoarthritis, we could say, this is caused by some wear on the knee joint. Pain from this sort of problem comes and goes a bit. You probably have a few good weeks and then a few less good weeks. We have 3 options. We can use some painkillers. We could use some painkillers with some exercises to do, which might be a bit painful to start with, but will usually help. Or we could do an injection in the joint. The injection's a bit painful and would cost $20. What would you like to do? Having given the options, you ask the patient to choose. The first time you do this, the patient may be confused. Many will say, well, I don't know, doctor, you tell me, you're the doctor. In that case, I usually say, well, if you were my brother or my sister or my mother, I would recommend this treatment. Using a phrase like that tells the patient that there are options. And as time goes by, the patients will start to make the choices for themselves. I am always surprised how often people choose the option of doing nothing. If the patient is involved in making the decision about which treatment or investigation they should have, they are more likely to stick to the plan. So that's the end of the essential skills: golden minute, DICE, and shared decision making. After the management plan is agreed, it's time to move toward closing the session. It's a good idea to go over the management plan again and to summarise what will happen next. We then need to check the patient has understood what they should do. One good way to do this is to ask, what will you tell your husband or your wife or mother about what happened at the clinic today? And to get the patient to explain in their own words their understanding of the next step. We also need to safety net, which means to tell the patient what to do if things get worse or don't improve. It is possible you've got the diagnosis wrong, or it's possible the treatment will not work quickly enough. You need to explain what they should do in these circumstances, and you need to be specific. For a patient with asthma, you might say, if you have taken your inhaler twice and your breathing is still not improving, go to the hospital immediately. Or, for a child with fever, you might say, if a rash appears that does not go white when you press on it, go to the hospital. Vague advice like, come back if you want to, if it's not better sometime, is not clear enough. Arrange follow-up with yourself or suggest they go to another health professional if necessary, and be sure the patient understands. And then say goodbye. You can now watch the third part of Dr. Duncan's conversation with Mrs. Jackson about her headache. How well does he handle shared decision making and closing the session?